Good morning, everybody. Okay, and we are live. If I could have some reactions to make sure that everybody can see me and hear me okay. Perfect, thank you. I'm starting to see some rolling in. Thank you so much. And if I could see just one more reaction, making sure that everybody can see the screen that I'm sharing. It should be a slide named Benefits of Echocardiography Quality Improvement Accreditation. Excellent. Thank you very much. We'll give just one more minute. Excellent. Thank you. I see some things in the chat as well. I really appreciate that. I'm going to give maybe a couple more seconds, maybe a minute, to let more people bring in. I do see a lot of folks have already joined. That's excellent. Thank you, everybody, for those reactions. That's reassuring to know things are working. Can hear and see the screen, but I can't see you. You're not missing much as long as you're being able to see the slides. That's the most important part. So that is excellent that way. All right. Why don't we just get started? People will start joining in as they come. So let me again just start by thanking you for taking the time out of your busy schedules. My name is Santiago Luna. I am a clinical specialist with Accreditation Canada. And today we're going to present information about the Echocardiography Quality Improvement Program, or EQI for short. Today with us, we have Dr. Anthony Sanfilippo. Among his many accomplishments, he is a professor of medicine and cardiology with clinical appointments at Hotel Dieu and Kingston General Hospitals. He is also a past president of the Canadian Society of Echocardiography, and he currently serves as the primary advisor and chair of the EQI panel. We also have Paul McMullen. He has been a cardiac sonographer for over 25 years, and through his tenure, he's got extensive experience not only scanning, but also as a manager and technical director for echo labs in both public and private practice. In 2013, Paul was invited to join the EQI panel, contributing expertise to provincial quality initiatives and helping shape standards that guide echo labs across Ontario. And he's been an assessor with the program ever since. At Accreditation Canada, we recognize the historical injustices faced by Indigenous cultures and communities across Canada. As we move forward, especially during this season of renewal, we are committed to the journey of healing, reconciliation, and decolonization. A few housekeeping items before we begin. If you have any questions, share them in the chat, and answered questions will be compiled in a shared document and will be shared after this session. Also, I would like to mention that this session is being recorded for future viewing. Accreditation Canada Diagnostics and the EQI program wanted to host this webinar to provide insights into the EQI program, to discuss the impact of accreditation on enhancing patient safety and elevating care standards, and help all interested get a better understanding on how accreditation supports facilities in standardizing operations, addressing diminishing resources, mitigating risk, and fostering continuous quality improvement. Today, we'll start with Dr. Sanfilippo talking about the history and value of the EQI program. And I will then give a comprehensive overview of what the accreditation process looks like. And then we'll have a conversation with Paul for a client perspective and EQI assessor perspective. We have time after this, we'll address some of the questions from the chat. To begin, I would like to share with you our mission here at Accreditation Canada, which is to empower and enable people around the world to continuously improve quality of care. Accreditation Canada Diagnostics operates as a business unit of Accreditation Canada, and it assesses the quality and competence of healthcare facilities performing medical testing specimen collection, and diagnostic imaging. And within diagnostic imaging is the EQI program. The program evaluates and supports echocardiography services to improve accuracy, reduce risk, and elevate patient care. The program covers all modalities of adult echocardiography, including transthoracic, stress echo, and transesophageal, as well as pediatric echoes. And for each of these, we have relevant program requirements, assessors, physician reviewers, and advisory panel members. And now to tell you more about the program's history and its value, I would like to invite Dr. Sanfilippo.
Well, good afternoon, everyone, and happy to be here and do this. And thanks, Santiago, for the invitation. We thought it best, most helpful to go back and look at how this came about. And although this came about in Ontario, I think as we discuss it, those of you who are outside Ontario, I think will appreciate that the issues that we've been dealing with are probably the same as what's happening across the country. Because the issue here is the delivery of echocardiography, which of course is similar and has similar goals wherever it's provided. So I'm going to give you a little bit of background about how we came to be where we are, a little bit about where we are, and a twitch about where we're going. Okay. So I think I can advance the slides. I'm not sure. Can I do that? Yeah. Okay.
Perhaps
so
not.
so I'm sorry, Santiago?
Perhaps not, but I'm happy to run the slides for you, sir.
Okay, thanks very much. Well, you might, I think you can open up this slide. So we all know Echo had humble beginnings. It was over 50 years ago developed as a bedside, bulky kind of tool that was found to be able to record heart sounds initially, and then squiggles on a page that related to the movement of walls, eventually images. And it began to get incorporated into the care of cardiac patients, and it was recognized early on that it had huge potential to provide enhanced care and diagnostics. And so a decision was made that it was one of those things that required both a professional interpretation and a technical component in terms of providing the examination. Initially, of course, they were all done by the bedside doctor, but as they became more frequently utilized, it became obvious that we needed to separate those two roles. And so in Ontario, and I think probably across the country, the responsibility for echocardiography became entrusted to the medical community. So the government basically said, look, this is important. You know where it should be provided, you know what's required, and we'll pay you for doing it. And they agreed across the country to pay technical and professional components. And those became schedules of benefits. Move on, Santiago. And so the diagnostic value increased as the technology had increased, and developers and providers of echocardiography equipment became very keenly interested and involved in its development. And so you can open up this slide, Santiago. And as a result, we developed a system that generally worked pretty well for all involved. So there were incentives for growth and innovation. There was an ability to adapt and expand technology. There was a capacity that allowed it to grow and allowed the industry of echocardiography development and the providers and the technologists to all work together. Go ahead. And of course, it advanced dramatically, as you all know. Various components came along. 2D came along, strain, early on Doppler, spectral initially, then color, and all these advancements that you're all aware of came along. And as each came along, the examination became more complex, and more components came into that billing algorithm. Go ahead. And so I'm going to just go through some milestones that have developed in the evolution of QA in Ontario. In as early as 1990 or so, a number of meetings started to happen between providers of the echo community. Go ahead. The Echo Society, the Canadian Society of Echo, was established in 1996 and had its first annual meeting in 1999. And one of the first things it did was publish guidelines for the provision of echocardiography. Now, it's important that these are guidelines. They weren't standards, they weren't requirements, but they were a outline of how an echo examination should be conducted, and more broadly, how the examination should be provided within hospital settings and community settings. Go ahead. And of course it grew. This is just data from our lab in Kingston, but you'll all have the same charts from your labs that over the years, every year we had more and more echoes to do because there were more things to do. There were more conditions. And all this was occurring in an open market economy, basically, with a single payer universal access system within each of our provinces. Go ahead. Now, about 2010, our ministry in Ontario began to get a bit concerned about this because the costs for echo were going up very, very quickly. And in fact, outpacing the growth in all other diagnostic modalities. Go ahead. And so we were presented with these kind of curves of gradually but steadily increasing costs over the years. And there were some peculiar aspects to this. Go ahead, Santiago. That the provision of echo varied tremendously across our province. Our province at that time was divided into 14 called local health zones, and the use of echo varied dramatically between them. And they also noted that the use of echo in Ontario was a lot higher than it was in other provinces and other countries. So some questions started to be asked about, what is are we using echo optimally? Nobody's arguing that it has value, but there's some odd things here occurring in terms of how it's utilized. Go ahead. So a initiative was set up by the ministry and the Ontario Medical Association and the Canadian Society of Echocardiography jointly to examine and revise the practice of echo. And it was entrusted to what was in existence then, the Cardiac Care Network, which eventually became Core Health, to support this process and to oversee the process. And an advisory panel was established to begin to develop this. And out of that came the development of standards for provision and accreditation of echo in Ontario. And that was an outgrowth of the guidelines document that was developed a few years before. So basically, the guidelines were translated into standards and standards are things that can be assessed. You can show that this is happening or not. There's evidence for these. They're objective. And this document has been revised a number of years, including most recently just in the last few months. Go ahead. Now, this all started in 2014 with a voluntary echo quality improvement program for facilities that wish to be reviewed. And several facilities came forward, in fact, a number of them, and that provided us great opportunity to test out these standards, to see how they worked. And then in a really important milestone of this was in 2016, when the Ministry of Health in Ontario connected the provision of review to the ability to bill for echocardiography. So participation in our process became a requirement for billing, and that, of course, got a lot of attention. And now over the years, and the next slide shows that the oversight of this is migrated through different authorities as they have changed. And currently, it is housed with Accreditation Canada, which for the last few years has been a very effective marriage, I think. Accreditation Canada has taken this on with vigor. It has taken in much of the expertise that was developed in the previous organizations and expanded that dramatically. And of course, Accreditation Canada has scope outside Ontario, which I think brings us to today. A few core principles that I think have been in place since this started, and I think it's important to clarify right up front for any group that's thinking about moving into the Echo QI domain. And that is about the core driving thing is it's all about providing the right exam for the right patient at the right time. Everything we want to do is directed at ensuring that that patient who walks into an echo facility gets the best exam possible and for the right reason. It's all about that. It's not about anything else. And a core principle from the start is that this is not an exclusively cardiology domain. You don't have to be a cardiologist to interpret echocardiography or to do echocardiography, but you need to be qualified. And And the fact is the qualification is embedded in the practice of cardiology in a very intimate way in the educational system, but that doesn't mean that others can't acquire those skills, so it is an open process in that regard. A third key principle is that we don't see echo and have never seen echo as something that can only be done in an academic hospital lab or even in a hospital lab. Echo can be provided in a variety of different settings, and it needs to be because our patients don't all live next door to a big hospital. Some of them don't even, a lot of them don't even live in big cities. So, and yet echo is important in their care as well. So if you're running in a small community, an emergency department, and are seeing urgent patients, then it's important that echo is provided there. And so we've gone with the principle that it should be available to all patients regardless of where they are. And the process has proven that. You'll see in a minute that it is certainly possible to do good echo in a variety of different settings. The standards themselves cover 6 areas that we believe are really critical to the provision of good echocardiography. Obviously, the examination itself. What are the components of a proper echo exam? The facility in which that examination is provided. What should that facility look like? What should that equipment look like? What sort of procedures should be in place? How it's reported. I mean, echo is a complex examination consisting of, as 80 or so different components, and it isn't easily delivered to the consumer. It has to be interpreted, and so the way that report is structured is critical. Who's doing it, and what are the qualifications of the physicians who are overseeing the lab, the physicians who are interpreting, the sonographers who are doing the examinations? For whom is an echo an appropriate examination? What are the indications? And how can a facility have mechanisms in place to ensure that they're maintaining quality assurance? And so those have been all distributed into, next slide, into a series of standards that have been revised over the years. But basically, there are a number of standards, 40 or so, that relate to the transthoracic examination. And there are some additional standards that relate to the transesophageal and stress echocardiography as well. And they're structured in these domains. And these are all in this standards document and easily and full access to anyone who wishes to see them. Go ahead, Santiago. So, and Santiago is going to go over this with you, but just an overview that the process has these 2 components: a pre-site accumulation of documents related to how the standards are being provided in that facility, and then an on-site review. And that on-site process is in many ways the most demanding, but also the most valuable, because it is the way in which we see that those standards are actually living, that they're actually working, and recognize that there are different ways they can work in different places. So the on-site thing is not just about us poking our nose in. It's about looking to see and helping a lab meet the standards in the way that's best suited for them, because every environment's a little bit different. Next slide, please. So just a few numbers about where we are. We currently have 685 active echo locations in Ontario. And 579 of those are fully accredited, and 106 are in various stages of provisional approval leading to accreditation. Those include 357 separate facilities with 328 satellite sites. So when we talk about a facility, it's the group of labs that may be separate. So a core lab may have separate facilities, or there may be a number of sites around a community. 91 of those are single site, single physician sites. And I wanted to make that point because, as I said earlier, this is not exclusive to big labs, right? These standards can be met in a variety of different places. We've carried out a total of 1,449 assessments in the last few years. And that's more than the number because a lot of labs are now in their second cycle of assessment or have required a second assessment to review things. We've had over 6,000 case reviews. Let's go ahead. There's a couple more. And I just want to make the point that everybody gets a quality improvement plan. Okay, so the process is such that everybody gets feedback. about what they're doing, and it's feedback that's intended to get them better, right? Again, the driving component of this process is it's not about shutting people down. It's about bringing everybody up to the standards, and there's been a remarkably gratifying response from the community because people want to do good work. And we know we don't get feedback that's negative. We get feedback that's I think welcoming of the input and the opportunity to have review from outside. And we have an excellent accreditation rate. With that philosophy, almost all our labs can achieve accreditation. Go ahead. And here's how they spread out in Ontario. And as you can imagine, they follow the population. This is the distribution of facilities. And these are in the various big postal code areas of Ontario. So it just makes the point that, our biggest population is around the Greater Toronto area. And so most of the echo facilities are there as well. But these facilities spread out all across the province. So there are 41 in the sparsely populated northern parts of Ontario. So the distribution goes with the population. Go ahead. And just a little bit about the profile. This shows that first graph shows that most of these are clinics outside hospitals, right? So about 15% of our echo facilities occur in hospitals. Only 3% of those are academic hospitals. Most of the echo occurs in the community, which is where the people are, right? That makes good sense. It's most of them are multi-sites, but we have about 40% are single-site facilities. Go ahead. There's two more here, Santiago. And in terms of the number of reading physicians, about 44% of our facilities have a solo reading physician, and you can see that the majority have 2 to 5, and some of the bigger labs have over 5. Most of our facilities are doing exclusively transthoracic, but there is an increasing interest in stress echo. In fact, a staggeringly increasing interest in stress echo, and about 7% of our facilities do transesophageal. Go ahead. A few years ago, in 2020, we published on some outcomes of 1,000 labs that had come forward for registration. And just put that number in perspective for you, our 1,045 labs is double the number of McDonald's restaurants we have in Ontario. It doesn't quite touch how many Tim Hortons we have, but it's a lot of facilities. And I just want to share with you some of the outcome data from that analysis. Let's go forward, Santiago. So the first thing to look at is just utilization, and this is the pure utilization of in the blue bars of transthoracic up to the year the Echo EQI program came into play, and since then. And I think you'll appreciate that if you look at the blue bars, the utilization of standard transthoracic has continued to increase, but at a lower rate. So whereas it was increasing at 6.7% per year beforehand, that increase is now about 2% per year. The other thing that happened, and this is about the same time, is the stress echo came on, and the ability to bill for stress echo came on. And so stress echo has grown considerably since then. And it actually now constitutes, it's plateaued off the last few years, but for a few years it was growing faster than transthoracic. So you see, even when you put them both together, though, that rate of increase is less than it was before. Go ahead. The providers of stress echo, the physician providers, this shows the number of physicians involved in stress echo between 2009 and 2018. And you can see that the number of cardiologists doing stress echo has gone up. The number of internal medicine folk that are qualified in echocardiography, but not in cardiology necessarily, has stayed a bit steady, gone down the last few years. But the number of internists and cardiologists has gone down dramatically. The hatched bars refer to folks who are doing low volume echocardiography, and there's much fewer of those than there have been in the past. Go ahead. This shows the what leads to non-compliance and just showing some differences. If you're in a hospital-based labs seem more likely to achieve compliance in hospital than clinic-based labs, but again, most of them do just fine. And similarly, academic labs, do very well. Community-based hospital labs do well as also, but have a little more trouble. It doesn't matter if you're a single or multi-site facility in this analysis, and it doesn't matter if transthoracic is your only modality. It does matter a bit if you have multiple physicians readings to echo, and that's probably because they're helping each other and teaching each other. And of course, the group of early adopters, which back before it became mandatory, did well, but that's because they were keen to do it, and it was a time when we were testing out standards. So that's what our data showed as of 2010, and I think the trends are continuing. Just go ahead, Santiago. In terms of money, and I think we have to look at that. The upper chart here, the blue part is the actual number of echoes done each year. Okay, and the projection of the early line up until 2011-12 is what the growth was doing and what the growth would have been. So the red area is the difference between the projected growth and the actual growth of echocardiography. And if you translate that into billing terms, if you look at what that means in terms of the dollars that would have been spent that weren't, there's a considerable savings because in terms of the difference in the billing over the years. And believe me, we've used this data to speak to government about the need for ongoing support of the program. Go forward, Santiago. So why is periodic review of the program next? Why do we keep looking at things? Because the practice of echo changes. So those standards change every few years because, as you all know, echo is different things. We learn from experience what works. We have modified our standards tremendously, particularly things like, for example, quality assurance. When we first developed it, we had the mindset that quality assurance looked like it would look in an academic lab, and that didn't always translate into other facilities. So we found different ways to do it, more flexible ways to ensure quality assurance. We learn what's needed, what labs need in terms of support, and finally, we've had organizational changes, and in Accreditation Canada, we've expanded the standards to meet more broader aspects of care delivery within a regulated environment. So what hasn't changed about EQI over the years is this commitment to quality improvement. It's still it's QI, okay? It's quality improvement. That's the heart of this process. What also hasn't changed, and we can just flick through these, Santiago, I think there's 4, is our approach to facility assessment. Our funding has remained continuous, and so far, ECHO has been supported by our provincial ministry. We've been prepared for the idea that it might have a user pay component to it at some point, but that's not yet come into play. And the awareness of the importance of access and need for multiple approaches. It's great to have quality echo, but you have to have echo to begin with. And so we've been cognizant as we develop these standards that we need to be flexible about that. So I think that's my and so what's changed in the last little while is we now call the standards requirements, and that's only to bring it into line with how similar processes are applied in other diagnostic modalities. The format of the document in the standards is a little different, and it's more compatible with what those who work in healthcare settings and hospital settings will be familiar with. We've had very few modifications to the process, but it's largely to simplify. So we tried to take out areas that were complicated and difficult to assess and made them more accessible. And we've started to address some non-echo public health requirements. So any facility needs to be cognizant of things like infection control, patient privacy, confidentiality, safety. And so we brought those considerations into the document as well as a matter of public health responsibility. So I think I think I'll stop there. And I know we're going to have more discussion about how the program works, and I'm happy to come back and answer any questions or participate in a discussion later on as well. But thanks again for the opportunity.
Thank you very much for all of that, Dr. Sanfilippo. I want to take these next couple of minutes to talk in more detail about the EQI program, what it does, what an assessment looks like, what happens after, and of course, what are the EQI requirements that are assessed. Firstly, here's the team behind the EQI program, our operations lead, Sharon Persaud, our strategist, Ryan Gillespie, clinical specialist, Amy Collins, and myself, and Ms. Barrias, our associate. Guidance from the leadership team comes from John McGraw and Mayank Khanna, both with incredible professional accomplishments and expertise. Now, let's dive into the assessment process. Starting with the word accreditation, which has different connotations to everybody. I know it changed for me when I started working with the EQI program. In short, is the evaluation of processes to ensure quality and competence through conformance to an acknowledged standard. It elevates the confidence of all involved, staff, patients, healthcare ecosystem, and it is a formal recognition of competence. For me, it basically means quality assurance tool. There is something very important to note. Apologies. The EQI program is able to assess these things because it has a systematic process and a structure requirements that helps evaluation. And there is something very important to note, which is that from inception, the EQI does assessments at a facility level and a clinical level. The program does not assess individuals or competency. The EQI requirements and the program itself have been created with this in mind. The latest EQI program requirements, which as Dr. Sanfilippo mentioned, were previously referred as standards, where the most recent requirements were published in April 2025, with the latest technical and legislative requirements related to Canadian and international markets. The requirements were developed and are updated with these 6 core principles: enhanced quality and safety, continuous improvement, qualified personnel, effective and robust systems, quality demonstration, and clinical appropriateness. Now, the requirements are structured across 10 sections, which is what you see on screen right now, and they follow the full workflow of an echo lab. So the organizational structure looks at clear leadership, confidentiality, and people-centered care. Quality management is about indicators, complaints, and documents that are handled in the facility. Facilities and equipment sections are to ensure the safe spaces and properly tested machines. The pre, during, and post-exam process cover patient identification, stat exams, contrast use, and how urgent findings are managed. And finally, the technology behind the diagnostic imaging, like PACS and cybersecurity, as well as infection control, are there to help protect both patient information and safety. So overall, it's a practical end-to-end framework that reflects what happens in the Echo Lab every day. This is what a sample of the requirements would look like. On screen, you have requirements 3.2, 3.3, and 3.4. You can see it includes the technical description as well as what to look for and any subsections that are needed. So 3.2, for example, is talking about the room where the echoes are done, and the subsections are pointing to specifics to be considered for facilities that provide stress echocardiography services and maybe even transesophageal. This now is a snapshot of the accreditation process. As you can see, it all starts with the facility reaching out and filling out an application. And then the program notifies the facility, accepting the application and providing a package with all that they will need to go through the process. This package includes a list of things the facility will need to submit, and that includes documentation like policies, procedures, protocols, as well as cases to be submitted for technical and interpretative quality. These cases are processed internally to ensure case review is done in a double-blinded manner so that the feedback provided is objective. After all of this, an assessor will visit the facility, and then the assessor notes, together with the analysis of the documentation and the cases that have been provided, is then compiled in documents that are shared with the facility. And I'll go into detail about both what the assessment looks like and these documents in the next couple of slides. After all of these, the facility may receive a certificate of accreditation, and that would culminate the accreditation process. And this cycle is repeated every 4 years. Now, the on-site assessment. This, again, is a date that is determined by in agreement between both the facility and the EQI program. And the day of the assessment, what you're seeing on screen right now is a agenda of what happens on the day of the assessment. So the day usually starts with a conversation between the assessor and the medical and technical director. This is generally a conversation to understand a little bit more about the idiosyncrasies of each facility. Generally, every echo lab would do the exact same things, but everybody may do things in a little bit of a different manner. So this is a conversation to understand a little bit more about the facility, so the assessor gets a better picture of the day-to-day operations of the facility. After that, there's a facility tour, so trying to move around the facility to see where the patient changes, where the exam is done, in instances of stress echo facilities, where's the crash cart, transesophageal, where does that happen, where are things cleaned up, all of these things. A modality observation happens on the day of, and that is with an actual patient, obviously with their consent, and it is one modality observation. So in instances, for example, of a facility where there's both transthoracic and stress echocardiography being done, we would only observe a stress echo being done, not also the transthoracics. So we only observe one modality that day. And then a review of cases from archive. This is an opportunity for the assessor to look into the PACS and look at random at historical cases that have been archived. Now, after the assessment happens, the assessor would finalize their notes, and that, together with all the documentation and the cases, would come to the program, and then a site report would be issued, and this summarizes all of the findings of the assessment process. And in this summary, each one of the requirements would be laid out, and they will be categorized as met or minor major non-conformance. Each one of these would have observations and also will have recommendations. These are basically suggested corrective actions that the program has seen has helped facilities in the past that have had these non-conformance address those successfully. That document goes together with a quality improvement plan, or QIP for short. And again, this one just lists the requirements that have non-conformances. And again, it would include the observations and the recommendations as noted on the site report. Upon receiving these documents, the facility has 30 days to develop an action plan to address non-conformances and then return it to the program. Again, these plans include things like updated policies, staff training. And again, I would like to mention that these are that the word plan is what matters here. We do understand that certain aspects do take longer than 30 days to implement. For instance, implementing quarterly meetings or anything, or procuring beds or chairs or other equipment may take longer than 30 days. So laying out a plan that the facility is committing to carry out is what the QIP is basically all about. So upon receiving the QIP document, the program would review to ensure that all the corrective actions and all these plans are appropriate to address that non-conformance. And perhaps there's some additional documents or cases that may be required. But once that is agreed upon, then the certificate is issued. Again, this is a sample of the certificate, what the certificate would look like, so that facilities can even post it proudly on their facilities. Again, this cycle takes about 4 years to be repeated. And again, once the facility has been accredited, it will be added to the list of accredited sites under the Accreditation Canada website. Also worth mentioning that the accredited facilities would have access to the Accreditation Canada echocardiography seal. And that is something that facilities would want to put on their test reports, operational documents, and even advertising materials. Now, to help people get prepared for these programs, we provide an educational program because we are here to support all throughout, even from before you send out an application. This educational program is called Preparing for the Echocardiography Quality Improvement Accreditation. Our next one is coming in February, at the end of February next year. It's a 6 hours course, which is divided in 3 parts under 3 Tuesdays consecutively, from 1 p.m. to 3 p.m. Eastern Standard Time. There's a QR code on screen for the folks that want to use their phone and have the link to go in and register. And I believe we were able to put the link on the chat as well for those that prefer it that way. Once again, I want to thank you all for this time. This is the EQI email where you can contact us to send over any further questions or inquire more, or even begin your process under the accreditation program. Now, with all of this said, I would like to invite Paul on screen, and I would like to start this with prefacing that Paul is got, excuse me, a very unique lens into the echocardiography landscape, mainly because he, as you heard on the bio, he's been scanning for a very good long time. He's also been he is a manager and technical director of both public and private places, and also he's been an assessor for the EQI program for a very long time. So with all that perspective, going to many different places and working in both private and public sector, he's got quite unique insights into what echo looks like all around. So I'll stop sharing my screen. And Paul, you can hear me and see me okay?
Yep, can you hear me?
Yes, perfect. Thank you so much. So once again, thank you so much for taking the time. And maybe let's just start with some questions.
Sure.
So your facility has gone through the accreditation process a number of times now. And I want to ask, how has this impacted your delivery of services?
I'll give you a little brief overview of what my history is. So as the technical director manager of Sunnybrook Health Sciences here in Toronto, we actually had our first lab accreditation back in 2004, and that was with an accrediting body in the United States called IAC, because back then we didn't have our own Canadian accreditation service. In 2012, of course, the first set of standards were released, and Sunnybrook was one of the first hospitals to volunteer for that process. And I'm happy to say we passed. Since then, in 2020, we were recertified with IQMH, and then finally we just went through the certification process again this year. So, I mean, with each accreditation, the main takeaway is you always get valuable feedback. There's always room to improve. We try our best to do a very thorough exam on every patient, but like I said, sometimes, little things get missed, not intentionally, of course, but the EQI program gives us that valuable feedback, so we know that we're doing the best we can and everything up to standard.
That is great. That does give a big sense of security, providing the service with that feedback for sure.
Absolutely.
That is excellent. Now, could you share an example where following the EQI recommendations led to perhaps a measurable improvement in patient safety or clinical accuracy?
Sure. Before accreditation, it was a common occurrence in our echo lab here at Sunnybrook, where we would get a CD sent of an echo done at an outside facility. Now, most times these were the cath lab cardiologists or our cardiac surgeons requesting these, and we would download it on the PAC system. And ultimately, the same thing would happen. We would get a phone call about a half an hour later saying, no, we need to repeat the entire echo. We don't see enough information here. Now, since accreditation came into play in Ontario, that really doesn't happen anymore. I mean, our cardiologists all know that if they get an echo that was done at an outside lab, for example, I'm also technical director of KMH, so they know if they get an echo done at KMH, that lab has been accredited and these echoes are to standard. So it's very rare that we would ever repeat an echocardiogram that was sent from an outside lab. So, I mean, that saves a lot of time for the patient. It saves a lot of time for the physicians. They get the information they want. And there's also a cost savings there too for the Ontario government through OHIP.
Absolutely, that makes perfect sense. Many clinics, especially in today's HR challenges, worry about the limited staff or resources. How would they implement the EQI program from what you've seen?
Well, I mean, the standards. Okay, so how does accreditation identify gaps in the system? Okay, so I mean, the standards clearly set out what are minimal requirements for lab equipment, including the capabilities of the ultrasound machines, the digital archiving system. They address many ergonomic concerns with guidelines on patient scanning beds, the ability to raise and lower them. And there's even a standard for the type of chair the sonographer will be using. Through the process, labs have a clear guidelines on lab protocols, and as such will be able to identify if their staff need any additional training per se. One I think of is when contrast first started coming in use and ASC put out the guidelines. A lot of labs realized, well, hey, if we want to make use of this thing, now we have to get our sonographers trained for IV insertion and the proper use of contrast safely. So it makes a big difference.
That is excellent. Now, perhaps you've heard this before. If a clinic says, why don't we just create our own internal quality process instead of joining the EQI? How do you usually explain the value of unbiased third-party validation based on your experience as both a client and also as an assessor?
Okay, so I mean, while an internal QI process is better than nothing, I would say that having a third set of eyes taking a look at your processes and your daily activities is beneficial. I mean, as we're going through our day-to-day activities, sometimes we tend to lose oversight over what we're doing. Sometimes we lose a bit of objectivity. And even though, we have good intentions to do things properly, we can miss opportunities to improve. So, as the standards change and develop, having that third set of eyes come along and, looking at your processes, it sort of keeps you on the right path. So, as things change, you adapt, you change your standards, you change your practices, and, there's always there's always room for improvement.
That's absolutely right. Something that usually when I am looking, we have introductory teleconferences with facilities before to let them know what's going to happen about a month and a half in advance. And something that comes up often, and I would like to share with everybody listening, is the fact that every facility makes very good SOPs, standard operating procedures for how to handle things internally all of the time. And there's this feedback loop between the patient and the staff and what they each needs that fits into that new workflow and that new SOP. And as facility and staff members do, they'll get very good at those processes, but inevitably every facility will develop these blind spots, inevitably. And then this third set of eyes, as you mentioned, which is the EQI program, are a very good way to show those blind spots because it's a very systematic and structured way to approach the day-to-days of the Ecolab. And being able to see those blind spots is usually extremely beneficial. So with that in mind, particularly in the facilities that you serve as manager and even technical director, um, what kind of benefits, if there's any specifics that you have noticed after the accreditation process has passed in your facilities for your staff, the organization, and even the patients? I don't know if you have
Uh,
any specific examples there.
So, the benefit to your staff is like, why do we all do this? We do this because we want to help people. That's why we do Echo. We're trying to help patients um, with their care. So the benefit to my staff here and at the other lab, I'm technical directors. We know that we're doing a thorough job. We know there is guidelines out there, and we know we are following those guidelines. Um, for the organization, it sends a clear message to your patients that if you have your test in our facility, you are going to receive the best possible care that's available. And of course, to the patients, for some, it's a very difficult time, just finding out, well, you have heart disease. So by coming into these accredited labs, they know they're getting the best possible care they can. And, that gives them a lot of peace of mind.
It's excellent. Um, because of the size of the facilities that that you are technical director and manager, you've had staff that have sonographers that have been there for long periods of time and also received new people coming in. Um, what is usually the reaction of staff going through the process for the first time? Do they understand? Is it easy for them to understand the value? Or is there much apprehension when they're receiving this new thing called accreditation?
Yeah. It's funny. I've been doing this a long time, and, I haven't come across a clinic or a staff member of a clinic that gets overwhelmed by the accreditation process. The most encouraging part of all this is everybody wants to do better. Um, it's great when you go into a facility and you're sitting there, you're talking to the medical director and you're sitting there and basically when we do go in, we will say, well, we did your case reviews and I will go over certain findings with them. And sometimes we find some mistakes in that. But the great thing is they all say the same thing. We want to get better. And that's so perfect to me. That's so encouraging that, it's almost like a provincial wide thing where, all the clinics have that one end goal of maintaining the standards and getting better at what they do. They want to help their patients.
Absolutely. We help the community by helping the patients, and everybody in healthcare
Absolutely.
field goes
Mhm.
exactly into with that mentality. And that is absolutely right. Do you have any advice for anyone seeking accreditation in echocardiography?
Yes, do it. Absolutely do it. Um, it gives your staff clear guidelines. It makes your patients feel more at ease knowing that they're coming to a good lab. When you first do it, and I'll be honest, that gathering the documentation and that it's a big ask. It is a lot of work. All I would say is it gets a lot easier the second time around. Once you have your documentation in order, it's just a matter of updating those documents. If you're going through it the first time, reach out to AC Diagnostics. They're good people. They'll help you. If you know somebody who has been through the process, reach out to them. They've been through it. They can tell you what to expect. You can even, if you want, reach out to me. I'll give you an honest answer and I'm happy to help. But the process is very much worth it. I think every lab should be accredited.
That's awesome. Thank you for that answer. I guess the one thing that I would add to that too is, and again, it's a very much appreciated candor saying that it is it takes work to, especially at the beginning when you haven't, but that also opens out the door to understand your processes internally a lot better and see where there's things processes, for example, in your own facility that have not been standardized or organized, to use a different word, to make sure that you have that checklist, to make sure that you're not missing something important in either echo protocols or cleaning protocols or anything else that we do on a day-to-day under an echo lab. So that is excellent. Paul, thank you so much for your time. Any last words to the folks that are listening right now?
I would just, just to underline again, I really honestly believe that this is an excellent program, and we're all doing this for our patients. So I'd encourage everybody to please get accredited.
Perfect. Thank you so very much for your time and for your expertise, Paul. Really, really appreciate it.
I know it's a nice way of saying I'm old, Santiago. I get it.
Really appreciate that. All right. We are coming to the top of the hour. We have 4 more minutes. I'll scroll through the chat to see if there's any big questions that maybe we can address, maybe 1 or 2. Oh, I see some have already been answered by our EQI lead.
And Santiago, there's also one in the Q&A as well. Q&A
Oh,
section.
thank you.
No problem.
That narrows it down. Thank you, really. Many residents have been asking if there is an anticipation that Ecolab licensing will be implemented in a way that restricts the opening of new labs, comparable to the current regulations for general ultrasound and sleep laboratories. So the EQI has only purview under echocardiography. Any other modality would generally run through other business units. I know, for example, there is a diagnostic imaging business unit in Accreditation Canada, and I am seeing Dr. Sanfilippo raising his hand. Sorry if you have something to add.
Yeah, I just want to emphasize that this is not a process that is intended to address utilization per se. Okay, the process is not intended to control or have some predetermined idea about how many echo facilities should exist in a province or jurisdiction or city or anything. That is clearly a mandate of provincial governments. And our role is to assess the quality of the facilities that are in existence. So if you're allowed to open a facility and within your province and your jurisdiction, that is not, we don't say yes or no about that. But we will happily review to ensure that the standards that we've documented are met. Similarly, we don't input about cost issues. We don't input about, just to get this out of the way, we don't determine how much should be compensated for a particular echocardiogram. And as I said it earlier, we don't assess individual qualifications. We set standards around the qualifications of the folks who are working in the lab, but we don't review individual performance. So it's important to draw those lines. And I think that's important because we can do this, as Paul said, with a view to what's best for the patient. We don't have our eye on that big picture of utilization, which is important, but it's not us.
Excellent. Thank you very much for that, Dr. Sanfilippo. Perhaps we have time for one more question. How much leeway do you allow in size of the room? Example, a perfect facility and space is found at 115 square feet. Would you require a rebuild to meet the 120 square feet requirement? So I think this is an important question because, again, there is a set standard or requirement for things like this. However, we do understand that there are certain limitations within everything. The main important part here is, for example, if there's a stress echo room, making sure that there is the capability of wheeling in a stretcher in case an ambulance needs to be called to make sure the patient is taken care of. Making sure that the layout of the room is optimized is something that could be worked around. Obviously, there will be an absolute moment where the room is just too small to be able to have both the patient and the staff be performing the study in a safe manner. But again, there are ways around it to make sure that the service is being done in an appropriate way, an appropriate facility, where everybody's not only comfortable but safe, to make sure the study is performing the best possible way.
Yeah, I would add to that, Santiago, just like when I do a site visit, my main concern about looking at the rooms is more patient flow. Can you do that test without your sonographer, your patient, your ECG tech tripping over each other? As long as there's good patient flow in the room, everybody has their room and all that, and the patient feels comfortable doing the test and all that, the 150 to 200 square feet that is in the standards for a stress echo room, it's, I mean, we're not going to tell you to rip down walls.
Thank you for that, Paul. Dr. Sanfilippo.
Yeah, Paul said it well. It's about functionality. It's not. We don't go in with measuring tapes. I would add though that we've had a lot of feedback from sonographers and physicians who've thanked us for providing feedback about space, because they can now validate concerns they've had for years to the folks who need to make decisions about space and about where the echo lab should be and how big the room should be for things like stress. So it would provide, I mean, sonographers know very well whether they've got enough space or not. This provides an objective external validation of what they often have been saying for a long time.
Excellent. Thank you so much. We have come to 1:02 at the top of the hour. I want to once again thank everybody for your precious time. I hope this was of value. Once again, our email is on the chat as well. And once again, feel free to reach out with any questions or concerns that you may have. And also absolutely to join us in this program, which again, as I hope everybody sees by now, is to make sure that we improve patient care, both for the community, the staff, and the patient, of course. Okay, perfect. Thank you so very much to everybody, and I hope everybody has a very good rest of the afternoon. Bye.
多謝晒。